This is a lecture recording on diseases of the hematopoietic and lymphoid systems. What we're going to do is start out by talking about red blood cell disorders and then move into white blood cells disorders and then finish up with disorders of the lymphoid system. Although for this lecture I'm dividing into these three categories, in reality the production, the function, and the destruction of any of these cell types are going to be closely linked. And so if you have a pathogenic derangement affecting one cell type, it can often lead to alteration of another cell type. So just keep that in mind as we go through the lecture. Okay, we're going to start out with red blood cell disorders. This is a microscope slide of red blood cells. This is using a Wright stain. That is WRIGHT stain. This is what red blood cells would look like under the microscope. Red blood cells are biconvex, and so when you look under the microscope, at the center here, it's going to look a little pale. And then along with the red blood cells here, you can see some platelets that are smaller in size, and with the Wright stain, it's going to show up as kind of purplish or bluish. So I want you to keep this in mind here as we go through the lecture and talk about the different diseases. You'll see that under a microscope the size of these red blood cells will be altered with the different diseases. So I just want to show you what normal looks like. So when I show you a pathological slide, you can see the difference. Okay, let's start out by talking about anemia. Anemia is not a disease in itself. It's just like a symptom, like a fever. But if you have anemia, you have to understand why and then fix the underlying cause. The technical definition of anemia is the reduction in the oxygen transporting capacity of blood, which usually stems from a decrease in the red cell mass to subnormal levels. There are several causes of anemia, and we'll go through and talk about the different diseases that cause anemia. The first thing we're going to talk about is anemia from blood loss, and then we'll talk about anemia that that is caused by increased red cell destruction, and then anemia that is caused by decreased red cell production. And then we'll, as we talk about these different diseases or different disorders, we're going to talk about how the cells, the red blood cells, change in morphology. If they're microcytic, that means the red blood cells are going to be smaller in size, and then macrocytic, of course, is going to be red blood cells that look larger than normal. And then with some diseases, the red blood cells will be normal in size, but their shapes are going to be abnormal. And we'll talk about a couple of diseases with abnormal red blood cell shapes. And then with each disease, we'll talk about how they manifest clinically, both acute and chronic manifestations. Oops, sorry. Okay. When we talk about red blood cell disorders, we're going to quantify these red blood cells in order to usually make a diagnosis. So these are just some terms that pathologists would use to quantify red blood cells. Mean cell volume, or the MCV, is just the average volume per red cell. Okay, the mean cell hemoglobin is the average mass of hemoglobin per red cell. The mean cell hemoglobin concentration is the average concentration of hemoglobin in a given volume of packed red cells. And then the red cell distribution width is just the coefficient of variation of red cell volume. These are just samples of some quantitative indices of red blood cell, but pathologists also look at the peripheral smears and subjectively judge the size, the color, and the shape of the red blood cells in order to make a diagnosis. So this table just shows the adult reference ranges for red blood cells. This just is a sample table. Um, One thing you have to note is that different laboratories have their own reference ranges, and that's because different laboratories see different populations. So this is just a sample table of reference ranges. But this table lists the average value of both men and women, and these are the different indices that we just talked about. And these are some other indices here. So when you get a red blood cell sample sent to the lab, this is usually what comes back, and if it's abnormal, it gets tagged, and so this will help point to a particular cause of a disease. Okay, so anemia of blood loss. Blood loss can be acute or chronic in nature. Acute blood loss would be like if someone was in a car accident and lost a significant amount of blood in a very short time. And when that happens, there is a compensatory rise in erythropoietin, which is a hormone that produces red blood cells, that controls red blood cell production. And so there will be an increase in red cell production, and also an increase in the number of immature red blood cells, and that usually happens within 5 to 7 days after the trauma. So chronic causes of blood loss could be due to like GI tract lesions or gynecological disturbances. GI tract lesion, let's say if you have an ulcer and you have slow chronic blood loss. Gynecological disturbance would be like abnormal menstrual period, so you're losing a more significant amount of blood than normal. And under these cases, the red blood cells are normocytic, so the size of it is normal and the color will be normal. Okay, another category of anemia is hemolytic anemia. So normally red blood cells have a lifespan of about 120 days, but in hemolytic anemia there is an accelerated destruction of red blood cells, and this destruction can stem from either intrinsic red cell defect, which are usually inherited, or from extrinsic factors, which are usually acquired. Here is a list of these hemolytic anemia disorders. We'll go through each one of them and talk about them in a little bit more detail. The first disorder we're going to talk about is hereditary spherocytosis. This is an inherited disorder, and what happens here is there's some type of genetic defect in the membrane skeletal proteins, mainly ankyrin and spectrum of the red blood cells, and when there is mutations of the genes that encode these proteins occur, there is going to be a formation of spherocytes. Spherocytes are just these cells that are not deformable, so when they pass through the spleen, they're going to be destroyed in the spleen. So this disease is usually transmitted as autosomal dominant, but there is a more severe autosomal recessive form of the disease, and it affects a small minority of patients. So if you were to look at a peripheral smear of someone with hereditary spherocytosis, you'll see that the spherocytes are going to be dark red in color, and you're not going to see that central pallor that I showed you with the normal blood cells. Okay, some of the clinical features of this disease, of course, is anemia, and because there's destruction of these cells in the spleen, you're going to get splenomegaly. The spleen is going to be enlarged, and the patient will experience jaundice. There's really no specific treatment for this disease, but if you remove the spleen, it will provide some relief for these patients. Okay, this diagram just shows the pathogenesis of hereditary spherocytosis. You can see the protein ankyrin here and the protein spectrum here. These proteins are part of the red cell membrane skeleton. And so when there's mutations of these proteins, what happens is the red blood cells will lose or shed the membrane vesicles here, and then they transform or become spherocytes. These spherocytes are not deformable or non-deformable, and so they get trapped in the splenic cords and then phagocytosed by the macrophages in the spleen. So this is a peripheral smear. You can see that the red blood cells are darker in color, and then some of these cells you don't even see the central pallor that I showed you with a normal red blood cell. Okay, sickle cell anemia. This is a disorder that we already talked about when we talked about genetic diseases, but since it is the most common familial hemolytic anemia in the world, I thought I'd discuss it again, and it's placed here in this lecture for also completeness sake. So as you recall, in this disorder, what happens is there is a point mutation in the 6th codon of the beta globulin. So instead of glutamic acid being produced, valine is produced instead. And so during deoxygenation, what happens is the hemoglobin S molecules will form long polymers with this abnormal valine residue. And so these polymers will distort the red cell, and it's going to assume, the red cells will assume an elongated crescent-like shape. And so the red blood cells will be rigid in appearance, rigid and sickled in appearance. Initially, the sickling of these red cells is reversible upon reoxygenation. However, with repeated distortion of the membrane and with the sickling episode, it will cause an influx of calcium. And with the influx of calcium, there's going to be loss of potassium and water, and so this will damage the membrane skeleton. So over time, this cumulative damage will create an irreversible sickle cell, and these sickle cells will be hemolyzed or broken down very rapidly. So with this disorder, it mainly affects people of African descent. And something I failed to mention last time when we talked about it is that for some reason sickle cell anemia provides a significant protective effect against malaria. I don't think it's known why, but that is something that they have determined, that with sickle cell anemia, it somehow protects these patients from malaria. Okay, we already talked about the clinical course of sickle cell anemia, so just review that. The only thing I want to mention again is that in sickle cell anemia, in the retina, you're going to see the vessels going to be more tortuous, and there's going to be growth of new blood vessel. And remember when we talked about that C-fan neovascularization, the blood vessel growth will look like a C-fan here, and the vessels are going to be tortuous in appearance. Okay, thalassemia. This is another disorder of hemoglobin. In this disorder, there is a mutation in the alpha or the beta globin, and that will reduce the synthesis of hemoglobin. And so if you were to look at this disease under the microscope, what you'll see is the red blood cells will be smaller in size, so there's microcytosis, and also it's not going to be as dark in color, so there's hypochromia, and there's going to be variation in the cell size and cell shape. So this disorder is common among people of Mediterranean, African, and Asian descent. These are regions in which malaria is more endemic. So as with sickle cell anemia, for some reason it's believed that this mutation will protect against one form of malaria called falciparum malaria. Okay, as you know, hemoglobin, adult hemoglobin, is a tetramer. So it's composed of two alpha chains and two beta chains. So the alpha chains are encoded by two alpha globin genes, whereas the beta chains are only encoded by a single beta globin gene. So the clinical features will vary widely depending on the specific combination of mutated alleles that are inherited by the patient. So let's talk about beta thalassemia. So if a person inherits one abnormal allele, they have what we call beta thalassemia minor, also known as beta thalassemia trait. But if they inherited two mutated alleles, then they're going to have what we call thalassemia major. So beta 0 means that there's going to be no beta globin chains produced at all, whereas beta plus means there is production of beta globin, except there it's reduced but still detectable. So if you have any combination of these alleles, then they're going to have beta thalassemia major. But occasionally a person could inherit two beta plus alleles and have a milder disease called beta thalassemia intermedia. Okay, with alpha thalassemia, remember with the alpha chains, it's encoded by two alpha globin genes. And so the severity of the disease is proportional to the number of alpha globin genes that are missing. In this disease, the gene is missing instead of mutated. So if there's a loss of just one single alpha globin gene, then the patient will be just a silent carrier. However, if there is deletion of all four of the alpha globin genes, then it's lethal, and it's usually lethal in utero. Okay, this is a table showing the different forms of beta and alpha thalassemias. In beta thalassemia major, there's going to be a combination of two mutated genes, either beta 0 or beta plus, and so this is a severe case. The patient will have severe anemia, and they're going to require regular blood transfusions. In beta thalassemia intermedia, the anemia is severe, but they're not going to require regular blood transfusions. In beta thalassemia minor, the patient will be asymptomatic with either mild or absent anemia, but then no red blood cell abnormalities will be seen. With alpha thalassemia, if the patient is a silent carrier, they're going to be asymptomatic and there's no red cell abnormalities. Remember, with alpha thalassemias, the gene is deleted, but in beta thalassemia, there's a mutation of the gene. So with alpha thalassemia trait, with most Asians, they're going to have this type of genotype where two of the alleles will be deleted. They can be asymptomatic, just like beta thalassemia minor. In some Asians and in black Africans, they usually have this genotype here. Again, they're going to be asymptomatic. So in hemoglobin H disease, 3 of the alpha alleles will be deleted, and this is a severe case. It usually resembles the beta thalassemia intermedia in terms of clinical features. And in hydrops fetalis, all 4 of the alpha genes are deleted, and so in this case it is lethal in utero without transfusions. Okay, this is a diagram showing the pathogenesis of beta thalassemia. I'm not going to go through everything on this diagram. The only thing I really wanted to point out is the pathogenesis of the skeletal deformities that are seen in beta thalassemia. So here you have a normal erythroblast that's going to give normal red blood cells. But in beta thalassemia, where there is a reduction in the beta globin synthesis with the relative excess of the alpha globin, it's going to create or produce abnormal erythroblasts, which will lead to ineffective erythropoiesis. So most of the erythroblasts will die in the bone marrow, and that will result in anemia. And with anemia, there's going to be tissue hypoxia. With tissue hypoxia, there is going to be an increased production of erythropoietin, which is the hormone that regulates the red blood cell production. And when that happens, there's going to be hyperplasia of these erythroid progenitors. So in the bone marrow, when there is hyperplasia of these progenitor cells, it's going to completely fill up the intramedullary space of the skeleton, and then it's going to invade the bony cortex. It's going to impair bony growth, and it's going to produce skeletal deformities. And that can be seen in the skull, bone of the skull. Okay, here is an X-ray showing the severe erythroid hyperplasia. So this X-ray here shows kind of like a crew cut appearance of the skull. It looks spiked or spiculated in the outer skull, outer table of the skull, and this is just due to extreme erythroid hyperplasia. Pretty neat looking, huh? Okay, so red blood cells are constantly being exposed to both endogenous and exogenous oxidants, and normally they're usually inactivated by reduced glutathione or GSH, but in this disorder here, what happens is one of the enzymes that is responsible for the synthesis of glutathione, glucose 6-phosphate dehydrogenase, or G6PD, is deficient. And so the deficiency of this enzyme will cause the red cells to be more vulnerable to oxidative stress, and this will cause destruction of the red blood cells and cause anemia. So the gene that is responsible for this enzyme is on the X chromosome, so it is an X-linked disorder. And usually deficiency of this enzyme will not produce symptoms until the patient is exposed to some environmental factor that can produce oxidants, such as some drugs or some infectious agents. Some of the drugs that can trigger this disease are drugs such as antimalarials or sulfonamides or aspirins, those type of drugs. So what happens in this disease is when the oxidants are now in high level, and they're now free to attack other red cell components, including the globin chains, and so these oxidized hemoglobin will denature and precipitate, and when they precipitate, they're going to be accumulated in the cell, and these accumulations are called Heinz bodies. There are several variations or variants of this disease, but only two are most significant: the G6PDA minus and the G6PD Mediterranean. The G6PD Mediterranean gets its name because it is most commonly found in the Middle East. Okay, in the lower right hand corner here, in the inset, you can see red blood cells, and inside these red blood cells you can see the Heinz body, these dots right here. These are just denatured globin proteins, um, that have accumulated in the red blood cells because of the increase in oxidative stress due to the deficiency of this G6PD enzyme. Okay, paroxysmal nocturnal hemoglobinuria, or PNH. This is an acquired mutation in the gene PIGA. This gene is required to synthesize PIG or GPI, same thing. This protein is important because it anchors the protein on the cell surface. So without GPI, some of the proteins can not be expressed on the cell surface. So most of the affected proteins are proteins that limit the activation of complement. And so when there is a mutation in this gene, and it will give rise to cells that are sensitive to complement mediated lysis, and so the red blood cells will be destroyed in this case. The reason this disease is called nocturnal hemolysis is because usually the fixation of complement is enhanced by the decrease in blood pH, and the decrease in blood pH is usually occurs during sleep. So that's why this is called nocturnal hemoglobinuria. Okay, some people will develop antibodies that will recognize determinants on the red cell membranes and cause hemolytic anemia. So these antibodies can arise spontaneously or be induced by exogenous agents such as drugs or chemicals. It's not a very common condition, and usually it's classified on the basis of the nature of the antibody. So the antibodies can be classified as either warm agglutinin, which is caused by the IgG antibodies. And the reason it's called warm agglutinin is because this antibody will not be active until it's about 37 degrees Celsius or higher. So only at that temperature or higher will the red blood cells be hemolyzed. In 60% of the cases, the cause is idiopathic, and in about 25% of the cases, it's caused by an underlying disease affecting the immune system, such as lupus, or if the patient has tumors or is induced by certain drugs. So for cold agglutinin, which is caused by the IgM antibodies, the red blood cells will not be hemolyzed at room temperature, will hemolyze at room temperature, which is below 30 degrees Celsius. And it's usually triggered by recovery from pneumonia by Mycoplasma pneumoniae, or HIV, or if someone has HIV, or mononucleosis. Okay, so the one way to test if the patient has these antibodies is a test called Coombs test. There are two ways to do it. It can be done, the direct way would be to test the patient's cells for the surface antibodies, but the indirect way is just to test the patient's serum for the antibodies. So a positive test result will be is when these antibodies will cause the patient's red cells to clump together, and that's how they're positive for this disease. Okay, hemolytic anemia is due to red blood cell trauma. So there are certain cases in which the red blood cells can undergo trauma. One good example of this is when a patient, let's say they have a mechanical heart valve that is defective. When it's defective, it can create turbulent blood flow, and so when the red blood cells flow across this defective valve, it can shear the red blood cells and break it. Another good example would be in certain conditions or diseases in where the small blood vessels are obstructed or narrowed by lesions, and so when the red blood cells pass through these blood vessels, it can cause mechanical damage. The most frequent cause of these small vessels becoming obstructed is disseminated intravascular coagulation, in which the vessels are narrowed by the deposition of fibrin. So other causes of these microangiopathic hemolytic anemia can include like malignant hypertension or lupus, um, or even in some cancers. Okay, this is just a peripheral smear of a patient that has hemolytic uremic syndrome. You can see the red blood cells here. They're fragmented and broken up, and that's just caused by trauma due to the red blood cells going through these blood vessels that are obstructed. Okay, malaria. Malaria is estimated to affect about 500 million people a year, and it kills more than 1 million people a year. It is endemic in Asia and Africa, but because people travel a lot now, it can be seen all over the world. It is caused by one of 4 types of protozoa, but the most important one is the Plasmodium falciparum. It is the most serious one because it can involve the brain. So all protozoas are transmitted by the bite of a female mosquito, and humans are the only natural reservoir. So as the mosquitoes feed on the human blood, the sporozoites are introduced from the saliva of the mosquito, and within minutes it will infect the liver cells. And here in the liver cells, the parasites will multiply very rapidly, and it will form what is called a schizont. And the schizont contains several thousands of merozoites. And when these merozoites are released or infect the red cells, then the patients will experience fever, chills, and shaking. The parasites will destroy large numbers of infected red cells, and that's why it's a hemolytic anemia. So when the hemoglobin, when the red blood cells are ruptured, the hemoglobin will release what is called hematin, and that's why you'll see this characteristic brown pigment in the spleen or liver or even lymph nodes of patients with malaria. So when this happens, there's going to be activation of the body's defense mechanism, and so it will lead to hyperplasia of mononuclear phagocytes, and then this will produce splenomegaly and hepatomegaly. Okay, I know I went through in a bit of detail with these hemolytic anemias, but in one slide here I have all the summary of all these conditions that can cause hemolytic anemia. So really this is pretty much the information that I want you to know for each of these conditions here. Okay, anemias of diminished erythropoiesis. Sorry. So these are conditions that can cause diminished production of red blood cells, and we'll again go through each of these in some detail. Okay, iron deficiency anemia. There are several causes of iron deficiency. Okay, in adult men, normally the most common cause of chronic blood loss would be blood loss from the GI tract. In premenopausal women, it's usually due to heavy menstrual period, and in postmenopausal women, it's due to blood loss again from somewhere along the GI tract. Another cause of iron deficiency anemia is just low intake or poor bioavailability due to a vegetarian diet. In some diseases, such as celiac, the iron is not absorbed properly, or in gastrectomy, in which the part of the stomach is removed, the iron will not be absorbed. So clinical manifestations, in most cases, if the iron deficiency is mild, the patient will be asymptomatic. In more severe case, the patient may get nonspecific symptoms such as weakness, listlessness, and pallor. But in long-standing anemia, you may see abnormalities such as the fingernails being thinner or flattened, or they may get fingernails called spooning, in which it's curved upward. Okay, so if you were to look at red blood cells in a patient with iron deficiency under a microscope, the red blood cells will be microcytic and hypochromic. So really the only way we can lose iron is by losing blood, because iron is not recycled. Okay, this is a peripheral smear. You can see these red blood cells are hypochromic. It's more pale than a normal red blood cell. They're smaller in size, and there is more variation in the size and shape of the cells. Okay, anemia of chronic diseases. Anemia that are associated with chronic diseases is the most common form of anemia in patients that are hospitalized. It can superficially resemble the anemia of iron deficiency, but arises instead from suppression of erythropoiesis by systemic inflammation. So it can occur in a variety of disorders associated with sustained or chronic inflammation, including chronic microbial infections or chronic immune disorders, as well as from neoplasms such as Hodgkin lymphoma and carcinomas of the lung and breast. So as in anemia of iron deficiency, the serum iron level usually are low in anemia of chronic disease, and the red cells may be slightly hypochromic and microcytic, but unlike iron deficiency anemia, the storage iron in the bone marrow is increased. Okay, when you have anemia of chronic diseases, you can give erythropoietin and iron to improve the anemia, but really the only effective treatment is to treat the underlying cause of the disease. Okay, megaloblastic anemias. The two principal causes of megaloblastic anemias are folate deficiency and vitamin B12 deficiency. These two vitamins are important because if you have inadequate synthesis of these vitamins, then you're going to have inadequate synthesis of thymidine. As you know, thymidine is important for DNA replication, so you're going to get defective DNA replication, and that's going to cause the hematopoietic precursors to be abnormally enlarged. And that's why it's called megaloblast. And then that's going to lead to abnormally large red blood cell production. Abnormally large red blood cells are called macrocytes. But not only the red blood cells are going to be affected, But the neutrophils and the neutrophil precursors in the bone marrow will also be large and hyperplastic. And if you were to look at the neutrophils under the microscope, they can be seen as hypersegmented. Okay, let's talk a little bit more about folate deficiency. Who would be at risk for deficiency in folate? Well, of course, those with poor diet, like those that are economically deprived or the indigent, and also elderly people are more at risk because of their diet. Another group of people that may be at risk for folate deficiency would be those that have an increased metabolic demands, such as pregnant women or patients with chronic hemolytic anemias. So when you consume folate, when you consume food that have folate and it's cooked, then in about 15 minutes, 10 to 15 minutes of cooking, this folate is destroyed. So the best source of folate would be fresh uncooked vegetables and fruits. So certain drugs, such as anticonvulsant and chemo drugs, can impair absorption or metabolism of folate, and also in a certain disease such as celiac disease, it can impair folate uptake. So what are some of the clinical features of folate deficiency? You can see the patients will experience symptoms such as weakness and easy fatigability, but in folate deficiency there are no neurological abnormalities. In vitamin B12 deficiency, there is there is some effect on the nerves. It can cause a demyelinating disorder of the peripheral nerves and the spinal cord. So what happens is when you consume vitamin B12, it combines with intrinsic factor in the mucosa of the stomach, and then it gets absorbed in the ileum, which is the lower portion of the small intestine. And so if there is any defect at any of these sites, it can produce megaloblastic anemia. So in pernicious anemia, which is the most frequent cause of vitamin B12 deficiency, there is an autoimmune reaction against the parietal cells and the intrinsic factor, and so that will cause the mucosa of the stomach to atrophy. So some of the clinical features you would see with vitamin B12 deficiency would be pallor, easy fatigability, and in severe cases you may see dyspnea, and congestive heart failure. And you may also see mild jaundice. So if the patient has a vitamin B12 deficiency, they can get a spinal cord disease. In that case, the patient will first experience numbness or tingling or burning in the feet or hands, and then that's followed by unsteady gait and loss of position sense, particularly in the toes. Okay, aplastic anemia. This is a disorder in which the multipotent myeloid stem cells are suppressed, and this will lead to bone marrow failure and pancytopenia, which means that there's going to be a reduction of both red and white blood cells as well as platelets. In most cases, or in some cases, the cause is idiopathic, but in most cases they're related to drugs, radiation, and viral infection. Okay, so if you were to take a look at the bone marrow in patients with aplastic anemia, you'll see that it is extremely hypocellular. There are not a lot of cells there. greater than 90% of the space will be filled by fat. And I'll show you a picture of that. What are some of the clinical features of aplastic anemia? You'll see the patients will be weak, they're going to be pale, and they may experience dyspnea or shortness of breath. And you'll also see thrombocytopenia, which could manifest as petechia or swelling. And then you may see granulocytopenia, which would manifest as frequent or persistent minor infections or by sudden onset of chills and fever. Okay, this is a slide that shows what the bone marrow of a healthy patient would look like. You can see there's a large amount of cells here, but in a patient with aplastic anemia, you can see the lack of cells. It's mainly filled by fat here. Okay, the last one, myelocytic anemia. In this condition, there is extensive infiltration of the marrow by tumors or other lesions. It is most commonly associated with metastatic breast, lung, or prostate. Oops, sorry, that's cancer. And the principal manifestation would be anemia and thrombocytopenia. So if you were to look under a microscope, what you would see is the red cells would be misshapen. It will resemble like a teardrop if in a peripheral blood smear. And you will also see granulocytes that are immature, and also erythrocytic precursors will also be immature, and that's called leukoerythroblastosis, along with a mild leukocytosis. Okay, again, what I did was I gave you a summary here of all the anemias that can are caused by diminished production of red blood cell. And so make sure you take a look at this slide. It's a good summary. It's pretty much everything I want you to know about these conditions. Okay, polycythemia. This is a condition in which there is an increase in red blood cells per unit volume of peripheral blood. So this is not a good thing. It's usually in response to an increased need, such as if you were living in a high altitude, or if you had lung disease such as emphysema. And also it could be caused by overproduction of erythropoietin in diseases such as renal diseases, or in cases where there are tumors. And usually this uncontrolled production is at the level of the bone marrow. Okay, so that's all I have for the red blood cells, and then we'll move in to the disorders of the white blood cells.